we know that if you don't sleep very well, it's likely to promote the development of dementia. So people with Alzheimer's disease, if they sleep well, their disease progression will slow down. But if their sleep's really corrupted, that'll accelerate the rate of cognitive decline as well.
Brilliant to welcome you, Dr. Dave Lee, to the Carecast today. Thank you very much for taking the time. And who isn't interested in sleep? What a fascinating topic. Who hasn't had problems getting to sleep or wanting to know more about how to help themselves? Sleep Unlimited. Obviously, it pretty much says what you do in the name, but can you tell me what you focus in on?
Sure. Yeah. So we're a group of health professionals, psychologists, and physiologists, and a few others as well. And we are bunched together to just basically assess and treat people's sleep problems. A lot of our work's in the clinical area. So I work a lot with people who've had significant injuries, accidents. But we also work with anybody who's not sleeping well, assess them and treat their sleep problems. We also do a lot of training. So we'll train health professionals more broadly so that when they go out and they're working with their clients who aren't sleeping well, they can then help get their clients to sleep better. And that helps with all the rest of the work that they might be doing with them.
No, absolutely. What's the current thinking about why, for example, a brain injury could lead to problems with sleeping?
Well, there's lots of factors around people, especially if someone's living with a significant injury. So there might be the actual physical damage to the brain as a result of the accident or the injury, or an infection. You could regard dementia as well as a type of brain injury that's kind of being driven internally. The structures in the brain, obviously, they're very complex and they're very sensitive and delicate. So any damage that's going on in there can have quite profound impacts on our ability to perform. And your sleep's controlled in your brain. So if there is damage to that part of the brain that's controlling your sleep, then we see sleep problems arising purely as a result of the damage to the brain. But then you've got an overlay on top of that. People might be worried or anxious. They might be living with pain.
Yep.
All these other then factors can then contribute to the sleep problem, which might then be an overlay on top of the actual brain injury itself. And then you've got other psychosocial factors that might be going on as well. So what kind of medication is that person taking? Certain meds interfere with sleep as well. What's the environment like at home? Are they now not sleeping in their old bedroom? They're downstairs in the front room because they can't do the stairs anymore. Is there more noise in that environment? So there's other factors there. So when someone's living with a sort of complex presentation, there's the internal physiological issues going on, but then we've got these other layers that can layer up on top of that, which might be more behavioural or psychosocial or drug related. So in terms of treating that person, you've got to tease that apart and say, well, what is the contributing factor here, and what can we then do about those?
Yeah, I suppose if I ask the question, what doesn't contribute or input into someone's sleep problems, it's virtually impossible to say, isn't it? It could be food.
Well, it's very idiosyncratic. Everyone's going to be in a different situation. How severe was the injury? Where in the brain was it? What are their circumstances like? What medications are they on? Are they living with comorbidities like pain? So in order to do good treatment, you have to assess people quite a high level of detail.
Yep.
Everybody's different. Yeah.
And I suppose the hormonal changes must be a very big contributory sort of factor potentially.
Sure. Yeah. So we'll see two periods in people's lives where the hormones make a big difference, and that's in the teenage years. And there's lots going on with teenagers. There's physical changes, there's hormonal changes, but there's a lot going on psychosocially as well. Exam stress, relationships starting and ending, all those stressful factors can contribute to poor sleep as well, particularly around the stress of exams. That's very common for your GCSE A-level students to get stressed around that sort of time, this time of year, really. And then more later on in perimenopause, sleep problems are going to affect about 1 in 4 people in their lives, but we'll see that going up to 4 in 10. So 40% of perimenopausal women will struggle with their sleep to a clinical level. So certainly hormone changes as we go through life are important, and especially around the menopause. Yeah.
And we haven't even mentioned devices yet. And so all that, but what inspired you to start up Sleep Unlimited. What was the spark?
The spark really is the sleep problems are ubiquitous. 1 in 4, I've just mentioned it. There's an awful lot of sleeping problems out in society. They contribute to a lot of accidents and injuries, which could be avoided if people weren't so tired. They massively contribute to a mental health status of our society. And we've seen that getting hit recently with the pandemic, especially. And poor mental health leads to poor sleep, but poor sleep leads to poor mental health. And these two things will feed back and feed forward on each other. So we've got a society full of tired people who struggle. They feel more pain. They're less happy because of that. And yet sleep problems are very treatable. You know, we've got really good interventions that work for about 70% of people who engage with them, which is a fantastic hit rate. You know, find me a drug that's anywhere near as good as that, and you've done very well. So we've got this nice set really of psychological and behavioral things that we can do, which are 70% effective. And sometimes they can work very quickly. So really the mission of us is connecting this technology, if you like, that's highly effective and often in a short space of time to the literally millions of people out there who need it. And we don't have a demand issue. There's plenty of demand out there for this stuff. The supply is the problem. It's about connecting this set of interventions that we've got to the people that need it. And there's a big demand out there. So what we're really, the delivery issue. So the mission is to teach the world to sleep. That's what the book's all about. That's what training all these health professionals is about trying to get information about cognitive behavioural therapy for insomnia, CBTI, which is nice guidelines. As I say, very effective. But the problem is we just don't have enough health professionals trained in this. So that's where we come in as well, training those who go out there and deliver this to the massive number of people that need it. That's the sort of the rationale and the drive. Yeah.
And so CBTI, cognitive behavioural therapy for insomnia, that's your number one tool in your toolkit, so to speak.
Absolutely, yeah. That's what NICE guidelines say we should do in the UK. The National Institutes for Health say the same thing in America. Every health commissioning body around the developed world now will say do CBT for insomnia because it's not toxic. It's psychological and behavioral stuff. The sleeping tablets are toxic and they cause a lot of problems. So that's why you go and see your GP and they type insomnia into their computer. CBT for insomnia will come out as number one treatment pathway of choice. But then the GPs get stuck because they're not trained in that and they don't know anyone else who's trained to deliver that. So they inevitably go to number 2 on the list, which is the tablets. And those are the only 2 things which are licensed for use in this country and around the developed world. CBT for insomnia or the drugs. Nothing else at the moment is licensed to treat a sleeping disorder.
If you had to explain to someone who didn't know at all what CBTI was, how would you explain it in a nutshell?
Yeah, dead simple, really. All it's doing is looking at the individual and putting in everything that sleep likes for that person, and then identifying all the obstacles that they might be experiencing and getting them away from bedtime. If someone's massively stressed and they can't switch off and their brain's going, then we need to work with their anxiety. If someone's just drinking shed loads of coffee and they can't get to sleep because they're buzzed up on the caffeine, then we reduce the coffee intake and we'll shift that earlier in the day so they're not caffeinated when they go to bed. Depends what that person's doing. So pretty much everyone could maybe tighten up their routine a bit. Sleep loves a good routine. So there's the very simple things. Just identify the things that sleep likes, do more of that stuff. And there's 2 big ones really. And I've just mentioned routine. Good sleepers tend to have good routines. Poor sleepers not. So tightening up a routine is a fairly straightforward thing to do. And going outside and getting exposure to natural daylight promotes your pineal gland in your brain to make the neurohormone melatonin, which I'm sure many of your listeners will have come across that. And that's sleep promoting. And we get loads more light pressure out of doors than we do indoors. So just spend more time out of doors, get more of that melatonin in the brain. Then when it gets dark, when the signal stops, brain says, right, release that melatonin, and that promotes us getting off to sleep. You get loads more of that outdoors than you'll ever get indoors.
What's your view on sunglasses?
Well, they will block out that luck getting in there. We evolved on a planet for 100,000 years without the Gucci's.
Yes, sorry.
100,000 years without
No,
Gucci's.
I think I think you've lowballed the figure there somewhat. I think
a long time.
when you look at that mechanism for producing, what's it called, the sleep hormone,
Melatonin.
we're probably into the hundreds of millions of years.
Oh, absolutely right. Well, if you want to get back into the brain, more those core bits of the brainstem are not dissimilar to your teenager's gecko, which make this stuff dinosaur, right? And the art is evolved. Okay, 100,000 years for humans is, but it's longer than that, right? It's millions maybe. And our eyes are really good at detecting the amount of light, and then our iris will then allow in the right amount of light for us. If people actually wear sunglasses a lot, you'll get the ultraviolet creeping around the edge, but the eye thinks it's darker, so the pupils will dilate, and you can get people getting headache if they're wearing glasses a lot because they're actually letting too much of that UV in around the sunglass. So your eye is better than anything at regulating the amount of light that goes in. But if you put something like that in front of it, you'll diminish that signal. So yeah, we'd want to avoid that. So those are the things that sleep likes: good routines and daylight, natural daylight. And then the obstacles, there's loads of them, but nicotine is a stimulant, caffeine's a stimulant, alcohol changes the structure of our sleep. Waking up in the night to use the bathroom because you're drinking too much in the evening. I mean, that is really common. That is really common. You would probably resolve 30% of sleeping problems in society right now by people not drinking before they go to bed. Getting up in the night to use the bathroom is massive. And that's a really simple one as well. So I think CBTI, because it's 70% effective, because I think it's really pretty straightforward stuff. Tighten up a routine, go outdoors, don't drink in the 2 hours before you go to bed, or eat or exercise, so you can relax and calm down and get off to sleep. I think that's one of the reasons why it's so effective. It's tapping into natural, evolved body processes and optimizing them, and it's getting obstacles out of the way. And you just do those two things, 7 out of 10 times people will get better. So it's simple, it's effective, and it's relatively easy for people to implement these sorts of things in their day-to-day lives as well.
I suppose that being overweight could be massive in snoring and sleep apnea and
right.
broken. Yeah. But do you?
Well, that's a good point, Luke. It's probably worth picking up on that, right? So CBTI 70% effective. Well, what about the 30%? And those 30%, some of them will have sleep apnea. Now, apnea is different. It's not an insomnia. Apnea is a dysomnia. We treat that in a different way. And you're right, being overweight and snoring and being male and being a bit older, they are risk factors for having apnea. And when we assess people, we'll screen for that. And if it looks like they're ticking a lot of risk factors for apnea, we assess them and treat them in a different way. Because apnea is more of a clinically significant issue than insomnia is. So we'd identify that at assessment stage and treat those people differently first. Yeah. If they still have insomnia after their apnea has been treated, they can always come back and do CBTI later on.
What's available for people with related sleep apnea?
So obstructive sleep apnea is often where you've got a large neck and the weight is crushing the windpipe when you lay down, causing the snore. We don't get enough oxygen in, which interferes with our sleep, which makes people feel very tired, and then they crash their car and they don't metabolize their sugar so well, so they actually put on more weight. Often you'll see people with apnea and you treat them, they lose weight quite quickly just because their sleep's better, they metabolize glucose better. So what's the pathway to that? Say again?
Tell us what's the mechanism there that better sleep leads to better metabolization of sugar.
So when you're sleep deprived, we've got two hormones which regulate glucose, leptin and ghrelin. And one of them makes you feel full up and one of them makes you feel hungry. And when you're sleep deprived, the one that makes you feel full up goes down and the one that makes you feel hungry goes up. So people who work night shifts, when they get a dip at 4 o'clock in the morning, only real solution is to go and find the fridge and eat your way through it. and you're craving all the bad stuff. Your
Yeah.
brainstem's detecting the leptin and ghrelin levels going wrong. I've not slept for 18 hours. I'm in some sort of crisis mode here. Get me some sugar so I can get through this crisis, get to a place of safety and sleep. That's the evolutionary biological explanation for why our hormones go out when we're tired, because I'm in some sort of danger here. I need to get to safety. Then I
Yep.
sleep, then the hormones come back. So you're constantly messing your routine, doing night shift work. Those hormones are never getting in balance. That's why you crave the sugar at 4 o'clock in the morning.
Yep.
And it's not a conscious thing. It's a brainstem thing. Eat the sugar, eat the sugar. Oh, I'm on a diet. I'm not going to eat the sugar. I'm going to eat the sugar, eat the sugar, eat the sugar. So
You can
you're just
resist it once or twice, but the tendency is going to be to listen to your body and to do as it's guiding you to.
your brainstem will override your intellect every day, all the time. Eat
Yep.
the sugar, eat the sugar. People smoke. They know it's bad for them, but they want the nicotine. Smoke. Yeah, it's animal instinct driven stuff. You're just not going to feel right until you've ate the sugar. And that's why we end up seeing so much obesity in shift workers.
Yeah. And
That can then crush the windpipe. They don't sleep so well, and that exacerbates the problem even more.
Worse. One more hormone that hasn't been mentioned, cortisol. What's the impact of poor sleep on cortisol, weight gain, stress, anxiety?
Yeah. There's a huge link between poor sleep and mental health presentations, broadly speaking. You can take a bunch of happy people and deprive them of their sleep for a few days. They'll get depressed and anxious very quickly.
Yep.
And it's two things. It's physiological. It's cortisol. And we know when people are sleep deprived in the morning, we all have what's called a cortisol activation peak in the morning, which is normal. When you wake up in a good routine, just about the time when you wake up, your cortisol level will go up. And that, we think, is to help us ping out of bed and get going and get ready for the day. So that cortisol activation peak is useful for us, but you'll get more of it if you're sleep deprived. So your cortisol levels are already elevated, which causes the stress response more broadly, systemically. So that's the sort of physiological effect. And we do see increased levels of cortisol in sleep deprivation. But then there's the psychological impact. Oh, I've not slept well. Or will I sleep well tonight? And then the worry and the anxiety creeps in, and that becomes a bit of an overlay then. So you do start to develop an anxious profile about sleep, and you need to wind this down to go to sleep. I'll use the example. If you're asleep in the next 5 minutes, Luca, I'll give you £3,000. Or if you're not asleep in the next 5 minutes, Luca, I'm going to come and shoot you. You're not going to sleep. You're way too excited. Anxiety and insomnia are very often co-presenting. And if people are too anxious and wound up, they'll struggle to get off to sleep. So sometimes it's physiological with hormone changes, and then that can feed into a psychological anxiety profile. Oh, will I sleep tonight? And then you've got a double whammy, and then they'll feed off on each other.
You mentioned shift workers. Obviously, there's lots of people that work shifts in health and social care and hospitals, as well as packing plants and food plants and all these sorts of factories. Other than to tell them to get a day job, how can those people protect themselves as much as they possibly can, given that the incredibly anti-normal situation that's kind of being forced on them?
It's really tricky. And we know that long-term untreated shift work increases comorbidity, reduces quality of life, and increased levels of mortality as well. And chronic long-term shift workers tend to die younger than non-shift workers purely as a result of messing around with their routines. So don't do it, obviously, if you can. We do a lot of work with employers on this sort of thing as well, like identify your larks. Some people like to get up early and go to bed early, and owls, they like to go to bed late and get up late, and just put the larks on the early shift and the owls on the late shift. Then they're late workers or early workers. They're not shifting. Then you remove the problem. So that's the best thing to do, is not shift people and let them pick the shifts that they want to do permanently. The other thing is to give people regular breaks from it. So they're working shifts for a while. They do 6 months of shift work, and then they maybe have 6 months not doing shift work to break it up. And the other big one that we'll talk about with employers from a management point of view is reduce the rate of rotation.
Yep.
So shift patterns rotate every 2 weeks. It's very common.
Don't do that.
Changing so free, 26 changes a year really messes us up. So we say stick a naught on it, rotate every 2 months, not every 2 weeks.
Strictly, in reality, it's a bit like sending someone on a holiday with a 9 or 10 hour difference in time zone every 2 weeks, isn't it?
Yeah, and it messes people up, and all their glucose metabolizing hormones will go out of sync, like we talked about earlier. Their cortisol levels will go up. They'll be more tired. They're more likely to crash their car on the way home from work. All of it.
My father-in-law swore that fasting for the period of time before traveling and then after traveling actually mitigated the impact of jet lag. He was a professor, and he would travel to far off countries and give addresses and things like that fairly frequently. And he felt that actually water fasting was probably the thing that helped the most. Why would that be? And do you agree with that?
Well, I'm not a nutritionist, so there are some bits around food and drink that come into sleep side of things, but yeah, I've not heard that. I mean, what you often find is people will come up with strategies that work for them. There may well be some scientific basis for that, but it's not something which I'm familiar with. Generally speaking, you want to be in a good routine and eating properly 3 square a day, not eating too close to bedtime, like we mentioned a little bit earlier on, and avoiding certain foods that can trigger sleep problems. So fatty, sugary things just before bed can trigger dreaming and poor sleep as well. So, but as for that to mitigate jet lag symptoms, I've not come across that before. No.
Yeah, I suppose that it was something to do with digestion, allowing digestion to switch off a little bit. And
yeah, there could be some sense there, because we do know when people are tired, you can feel a bit nauseated, hungry but sick at the same time. You know, that the feelings of fatigue, not nausea, and feeling hungry but not hungry at the same time is a common symptom of being tired. Yeah.
Can you explain the REST program and how it utilizes CBT therapy for insomnia, please?
Yeah. So our REST program is a CBTI program, but we've adapted it. It's a second generation model, if you like. We've had CBTI since.
What's the acronym stand for? REST?
R is routine.
Yep.
Talk about that. E is environmental.
Yep.
Considerations. S is what we call in the sleep world stimulus control. So there's certain behaviors which we'll engage in which help. So we mentioned going outdoors and having a good routine. So that's good stimulus control. And also there's poor stimulus control, eating, drinking, smoking, alcohol, too close to bedtime. These are stimulating and are obstacles for sleep. So the S element is about the behavioral things that we do that can help or hinder. Do more of the help, get rid of the hinder stuff. And then one of the things CBTI isn't great at conventionally is the C bit, the cognitive bit. Most of CBTI is actually BT, is more behavioral therapy. And it criticized, conventional CBTI models are criticized by being a bit weak on the psychology side of things. Yes. And that's the T bit. Well, I want a T for rest, don't I? So RESP for psychology, or RESC doesn't work. So we've called the cognitive, the psychology bit, thinking, which gives us our T. So we'll focus a bit more on, most people who don't sleep well are at least a bit anxious about, and they're a bit fed up about that, a bit of low mood. So the thinking side of the treatment protocol there is to work with anxiety, depression, trauma symptoms, maybe whatever other some more psychological presentations might be sitting in front of us, is to assess and identify those issues under the more psychological side of things and treat that as well. So helping people establish routines that will work for them, optimizing their environment for sleep, adjusting their behaviors, but also looking at their cognitive performance around sleep as well and how they think and feel about it. And then if you attack those 4 domains, you get better results. So conventional CBTI, 70%. our rest program, because we're adapting it and bespoking it to that individual, we spend a lot of time assessing the person to start with and say, well, what bits do you need out of RE, S and T? And we build that package for you. That makes patients feel a bit more held, that actually this intervention is not just off the shelf, there you go, that's for you, just like everybody else. They feel like it's being designed for them, and it is. And that improves compliance, which is everything with this stuff.
Yeah.
So we're taking our efficacy from 70 up to about 80% now, even in quite complex client groups, because we're tailoring that set of interventions to the individual.
On the subject of compliance, I don't know if you've seen his comedy routine, but Michael McIntyre does a great one where he's packing to get ready for going on holiday the next day, and he just can't resist doing all the wrong things, drinking too much and staying up to about 4 a.m. when he knows he's going to get up at 5. It's quite funny. It's hilarious. And just recently we went on holiday, met some friends, and they'd done exactly the same thing. They knew they had up early.
Yeah.
They stayed out late and turned up on the first day of the holiday, shattered and hungover. Why won't people do that? What?
Oh, that's just the human condition, isn't it? It's Well, it's I don't know if you remember that Candid camera from the 80s, and there's a classic one where they put a Venus de Milo David figure in a naked statue in the ladies' toilets, and they put a little fig leaf over his. Do you remember that scene? And like a little sign that said "Do not lift," and every single woman went in there and lifted it, and they had a little camera in there, and it set an alarm off, and they're and it's all very funny. We just if you make it forbidden, don't do it. People are going to do it. So that's actually quite an important point around compliance with this stuff. CBTI is not stop. It's change when you do. So drink, eat, look at your screens. Just don't do it in the 2 hours before bed. So it's not stop doing it. It's just change when in the day you do that stuff. Put the emails down after 9 o'clock at night. Have a couple of hours to wind down. You're going to get off to sleep. Oh, yeah. Rather than, I'm checking my emails till 11 and then there's a message from my boss and then you're just going to bed all keyed up. So it's this 2 hour rule we have for the obstacles, really. So I think that's another reason why it's well adhered to and is effective, because we're not preaching to people. We're not saying stop doing this. We just say change when you do it. That's all. Yeah.
David, what are some of the most common sleep problems you encounter, and what are the typical approaches to addressing them?
Again, very much depends on the individual. If you want to look really broadly, I think one of the most common things people will do will be getting up in the night to use the bathroom. And that's very simple to deal with. Just don't. What
impact does that have? Does that really degrade quality of your sleep if you have to get up and have a wee?
Well, if you go back to sleep again quite quickly and you get enough sleep for you, then no problem. But the problem that we do have is that once people wake up in the night, they've relieved some sleep pressure.
Yeah.
So it's our tiredness, and sleep likes tired. So it's good to be tired at bedtime. But then if you've been asleep for 4 hours and you wake up and use the bathroom, well, you're not so tired anymore then, and it's hard to go back to sleep. So people then struggle getting back off to sleep. Now, there's one thing insomniacs hate is the brokenness of their sleep. So anything you can do to consolidate it into bigger chunks, they like that. So now if you haven't got a bladder full of liquid that's waking you up in the middle of the night, well, now I'm going to sleep in one big block, not two separate blocks. And I like that. That makes me feel happy, but I'm also then not having that sleep disturbance. I get more sleep. That causes me to feel happy, refreshed, functional. And it's really common, like really common. Loads of people get up in the night to use the bathroom. I must hydrate. I was so worried about not being hydrated. Fine, drink as much as you like in the daytime, Marjorie. I don't care. Just don't do it in the 2 hours before bed. You void your bladder before you go to bed, less likely to wake up in the night. And I've seen that work hundreds and hundreds of times, sometimes really quickly. So I think if you ask me what the most common one is, that's right up there. And of course, it's more significant for older people because there's age-related weakening of sphincter muscles around the bladder. So people get up more in the night to use the bathroom. And I suppose the other thing we're seeing more and more of these days is the screens and the stress that you get from doom scrolling. We know that's impactive. And also the blue light that comes out of these reduces your melatonin secretion at night. And you don't get such good quality sleep if you've been staring at these a lot. And we're doing more and more of this, and it's causing more and more issues for us. So we're getting a bit concerned about the flat screen devices as well. Yeah, so try and avoid them in the 2 hours before bed.
How many people are you able to help each year through Sleep Unlimited? How many clients might tend to come across your books?
It depends which clients. So we do a lot of training, and we've been doing the training now for decades. And we probably are up to about 8,000 health professionals. So we probably train, what would it be, sort of 600-700 a year, maybe. My clinical specialty, people who've had brain injury. 65% of them are adults, 35% are kids. Most of the children have had birth trauma. Most of the adults, it's road traffic or falls. We probably assess and treat about 100 medical legal cases a year with that. And then others come and find us just on the internet. And there's, people just get in touch all the time, just off the street, really. And probably a few hundred of those a year as well. And we'll plug them into our psychology team for assessment treatment. So different types of people in different ways, lots of training and helping health professionals, but also direct assessments as well.
Yep. What are your top 3 tips for someone who is looking to improve their sleep?
Good routine, a routine that works for you, that gets you the right amount of sleep for your age. Kids need more sleep than adults do. So getting a routine that suits you. If you're a lark, go to bed early and get up early. Don't get larks to stay up past midnight and get up at 10 in the morning because they won't do it. If you're an owl, set a routine that's going to work for you. Don't force yourself up too early and bed too early because owls don't like that. So number 1, get a good routine that works for you. Number 2, spend as much time as you can outdoors to signal that melatonin production. And then the third thing is, identify what obstacles you've got in your life that are getting in the way of sleep. Are you consuming stimulant things near bedtime? Are you drinking, eating lots? Are you on the blue screens at night? And what is the obstacle or obstacles in your life that might be stimulating you at bedtime? And just stop it. Or do it earlier in the day.
On the specific question of stimulants, let's say caffeine, I think there's a sort of perception that most of the caffeine is through your system after about 6 or 7 hours. So if you have 5 cups of coffee in the morning, it's fine. It's not going to impact on your sleep, but I'm not sure about that. I'm thinking that caffeine's got quite a high half-life and it stays in your system really.
Half-life word. So it's got a half-life of 4 to 6 hours. So if you have a mug of coffee at midday, at 4 in the afternoon, half of that coffee's gone. 8 o'clock in the evening, a quarter's gone, and at midnight, an eighth has gone. So it goes down in half.
Or an eighth remains. Is that?
Yeah, that's right. So 4 in the afternoon, half the coffee remains. 8 o'clock in the evening, a quarter remains. Midnight, an eighth remains. So it's not, if I have a cup of coffee, it'll all be gone in 4 hours. It won't, half of it will.
Yeah.
So if you're drinking coffee, say 6 o'clock at night, well, half that coffee is going to still be in you at midnight.
Yeah.
But if you've had 6 cups of coffee in the day, well, you're just topping that up all the time. So actually, you might have quite a lot of caffeine still in your system if you're drinking a lot of coffee throughout the day. So we've got this 2-hour rule, avoid the obstacles in the 2 hours before bed. Caffeine's the one exception to that. Especially if people are struggling to get off to sleep, they're caffeinated, they're stimulated. Try and leave the coffee alone after lunch is the advice there. Oh, yeah, you want me to leave the coffee alone after lunch, Dave? Okay, bye, and you've lost them. So we grade it in. Well, when's your last coffee, Marjorie? 6 p.m. Right, can you do 5 p.m. for a week? And then 4 for a week, and then grade it back. So caffeine's a tricky one because it's really stimulant and it's got a long half-life. And we're seeing it everywhere.
Yeah. I heard a very good take on coffee recently, which was quite persuasive, which is that basically coffee plants make their seeds poisonous to stop animals eating them. And the poison in caffeine, it kills or impacts on the ability of, say, insects to reproduce, and probably does similar things to us. But if people keep that thought in their head, I think it might help a little bit. It's not some amazing potion, which is just all good. Obviously, we know caffeine can be bad as well, but the plant has developed, it's a chemical warfare to
That's right. Yeah.
know what
It's like,
comes away. And,
it's like
we're using
nettles having their stingy bits in them, isn't it? It's a
yes.
protection mechanism. Absolutely. Yeah.
Yeah.
And it's highly addictive, caffeine. It's hard. A lot of people might have tried to stop it. And I ask in training a lot, has anyone given up caffeine? And a few hands go up, and they say, well, keep your hands up. Are you still off the caffeine? Oh, no, I've started again. Yeah. It's really hard to keep people get headachy and angry. It's hard to get off it. Yeah. And it's everywhere. And we're seeing it being supercharged at us now with these energy drink cans, absolutely loaded with caffeine.
Yeah.
And there's a lot of people which are consuming a lot of them, more and more than we ever have done, really. And it's contributing a lot to sleep problems. Yeah.
Beyond insomnia, what other sleep disorders do you commonly address, and how do you help individuals manage them?
So sleep apnea is a very common health condition. We've got about 330,000 people diagnosed with it in the UK, but a lot of people have it and aren't aware they've got it. Now, we think there's about 1.5 million people out there with apnea. Now, you've got to be very careful when you're engaging in safety critical tasks when you've got apnea, because you're very tired in the daytime. So driving is very difficult. And in fact, the DVLA will stop you driving if you've got apnea until it's treated, and your compliance with treatment, and you get reviewed every couple of years, and then you get your driving license back. So it's quite a common condition that a lot of people have that they don't know about. So when we assess people, we screen for sleep apnea, and we'll treat that differently. They're then fed off into a different treatment pathway. And if they haven't got apnea and they're more insomnia, that's when they would get the rest program, CBT for insomnia. So we're always screening for that. There are other conditions as well. Some of your listeners might have come across narcolepsy, where people can fall asleep uncontrollably. That's actually quite a rare condition. It's a genetic condition. So we don't see very much of that. And there can be all sorts of other things which might set things off. Some people can have vitamin deficiencies. They might need a blood test. They might need to do some dietary adjustment or have some supplements prescribed by a GP. So we'll look for all of those sorts of things. And then we'll try and put in the appropriate treatment for that person once we've effectively diagnosed them. So that's where our processes start: diagnostics and assessment, and then triaging people into the right care pathway from that point there.
If you were, obviously, at a living care company, we provide living carers throughout the UK. If you were a living carer looking after someone, whether they had dementia or not, and you wanted to implement a few things, if your client was, their sleep were not optimal, what sort of thing would you look at to just try to help someone? I think you mentioned not drinking water these 2 hours before bedtime, things like that. Would that be one of your go-tos?
If it's an issue for that family, for that client,
if you're talking about being someone who's trying to influence someone else to improve their habits, but in a quite a gentle way, would those things be?
Well, I mean, we know that if you don't sleep very well, it's likely to promote the development of dementia. So people with Alzheimer's disease, if they sleep well, their disease progression will slow down. But if their sleep's really corrupted, that'll accelerate the rate of cognitive decline as well. Now, we know that a bit of napping can be neuroprotective for people with dementia if they do it for an hour or less a day.
Yep.
But if they're napping for more than 2 hours a day, that's reducing their sleep pressure at night, their tiredness at night. Their sleep's then much more likely to be corrupted, disturbed in the nighttime, and that will accelerate the rate of decline. So if someone's living with dementia, a little bit of napping in the daytime is a good idea, but not too much. But if they're not got dementia, we don't want them to nap, because I want you to be nice and tired at night time. So your sleep pressure is very high. You're much more likely to get to sleep and stay asleep then. So who are we looking after? If it's someone with dementia, sure, they might want a bit of napping. If they haven't got dementia, then probably avoid the napping behaviors.
Yep.
So that's something behavioral that we can adjust, tightening up routines, getting people outdoors. A lot of my work in the early days of my sleep career back in the early 2000s was measuring the sleep of people with dementia and their carers at home, but also in the hospital. And we're rubbish about getting people outdoors in the
I mean,
hospital.
I was going to say, there's absolutely zero protocol. You never go past a hospital these days and find, for example, nurses or auxiliaries pushing someone in a wheelchair outside so that they get some fresh
And
air
I
and some. Back in the day, if you look at films where they
Yeah.
portray hospitals, the doctors and nurses wheeling people around
the old
outside.
TB hospitals, it was outdoors, and it's the fresh air that will help people. It probably wasn't actually. It's much more likely to be the natural daylight, which helped them get better. But we used to do that, and we're rubbish at that these days. I mean, the course of my
zero. We don't do it at all, do we?
No, don't do it at all. So I probably went around 30 community hospitals measuring sleep in and around these settings. Every small town's got one, and they're square or U-shaped buildings around a quadrangle, the garden in the middle. All the wards have double doors that open onto these gardens. And I never, ever, ever saw one patient sat in the garden.
No.
The only people you ever see in the garden are the gardeners making it look pretty. And back in the early 2000s, the odd visitor having a fag.
Yeah.
But that you never saw a patient. Because if we open the doors, they might run away. So we don't. We lock these people up, and they're already quite oppressive environments anyway. And people like being outdoors, but for some reason, it's still too difficult to open the doors and let these people outside. So it certainly would be advocating that. We'll see some excellent results with people spending time out of doors. So I'd look at napping behaviors and I'd look at time spent outdoors, look for the obstacles, the drinking, the stress, but also, and this is really important, we don't do this very well either, I'd be looking at the carers and saying, well, how are you? We're entitled, if you're a full-time carer, you're entitled to 2 weeks a year of respite care. How many carers actually get or are even aware that they're entitled to that? Because carers need a break too. And we know that sleep disturbances in dementia caregiving is the number one reason for care breaking down at home. And people then having to go into long-term institutional care settings.
With that, that's what we observe as well.
Absolutely massive. And there was a good study done a long time ago now by John Sanford, and it was in the BMJ. And he looked at the breakdown of care in the community and the reasons and the tolerability of certain behaviors. So it was something like 85+% of carers described sleep disturbance as being a big factor for them. Only 16% of them could tolerate that. The next down was fecal intolerance. 40% of carers said that was a really problematic experience for them, but about 40% could cope with it. 16% coped with the sleep deprivation.
And you're also talking about familial care spouses and things like that, aren't you?
Yeah. That's that study.
I mean, from our point of view, if you look at living carers, some can tolerate some sleep disruption, but it is the biggest reason why sometimes things can break down. The fecal intolerance. Yes, some carers prefer not to manage that, but we can always find care that can manage that. So that it actually breaks down.
That's tolerable,
almost
tolerable than the sleep. Yeah. So actually investing in providing support for carers, family carers, and living care, professional carers as well as attacking the sleep problem from the patient's point of view. Do that two-pronged attack, treat the patient, but also looking after the carer as well. Then they've got more resource available for the caring role. The patient's better rested, so their rate of cognitive decline slows down, but also they'll be happier. You'll see less challenging behaviors, which make caring for them easier to do. And caring roles are often associated with a lot of pleasure as well. And you'll see the more positive sides of caring start to emerge when patients and carers have got the energy and they're better rested. So there's a big public health argument here about supporting people with dementia and their carers with their sleep at home, because they'll stay at home for longer. And when they go into hospital, they're very expensive to look after as well. So promoting that, extending that care in the community is definitely a good idea from a public health expenditure perspective, as well as the human side of things, keeping people out of hospital and at home with family members where they want to be.
Penultimate question, David. As a therapist and psychologist.
Yeah.
Yes.
Yeah.
How do you stay in your lane? Obviously, your lane is sleep, but everything contributes to that. How do you sort of sometimes
Yeah. So my lane is broad.
yourself? Yeah,
It's more than one lane, because sometimes it's a psychosocial issue, sometimes it's a behavioural issue, sometimes it's an economic issue. We have to move people's houses sometimes and get them to the right place to sleep. So it from my point of view, it's endlessly fascinating, because every day is different for me. Every client I work with is different. That I have to think broadly sometimes about, well, who's in front of me and what are their specific needs. And sometimes they can be quite sort of left field things that we can or can't do for, say, cultural reasons, maybe. Or is this actually, we need some money here, we need to apply to the courts for interim payments to get that person the supportive bed that they need. I mean, it's always different. It's always endlessly fascinating. But I think you get good results if you really spend a lot of time assessing that individual and identifying what their specific situation and needs, and then trying to tailor your interventions to that person. And we'll often traffic light those, or actually, here's some red things. Let's do these 3 things first. And here's some amber things. We'll do them later. Especially when we're working with complex clients where you might have quite a lot of stuff you want to do, but that would be too overwhelming. So it's put in what that person needs right now, and then we'll follow up next week with that, and next month with that, and gradually build in. So yeah, I think it's great for me, because it keeps me sharp.
how someone would get in touch with you, whether they wanted to put some training for them and their staff, or maybe one of their clients might need your help, or they themselves or a family member really do with some support around sleep.
I would just very simply, we're on the internet, look for sleepunlimited.co.uk. Our phone number's on there as well, 01915800008. Or you can drop us an emails, info@sleepunlimited.co.uk for inquiries, training@sleepunlimited.co.uk for training inquiries, or just come onto the website and click around, and there's details about the assessments that we do, the treatments that we do when we're working with more complex clients, media inquiries, and booking training, and the training sessions that we've got coming up. So yeah, all the details are on the website. It's probably the easiest way to find out more about what we do. Or if people are just interested, generally, the strapline be teaching the world to sleep. That's the name of my book as well. So there's loads more details about CBTI, the REST program that we've been talking about today. And the back end of this book is how we'd apply those interventions to more complex groups. So there's sections on people with dementia, carers, people who've had stroke, brain injury, drug and alcohol use, menopause, neurodiversity, all of that. The little adaptations we do to the model is in the back of the book there. So for sensible people, the easiest way to treat you is treat yourself. Go and buy that, read it, and treat yourself. Give some of this stuff a go. But if people are still struggling, they might be in the 30%, and they might want to get in touch and have a bit more of a chat about a more detailed assessment if that's required.
Amazing. Thank you so much for your time, David. Truly been extremely interesting, and much appreciated.
Thanks for inviting me. Good questions. I hope that's been useful for you and for your listeners. And yeah, take care, everyone. Sleep well.
Take care. Bye-bye.
Cheers.